Hi, good evening to everyone. I'm Dr. Philip McMillan. Um, I'm a physician and I have been focused on COVID 19 since early 2020. My approach to it has been that it's been a viral autoimmune disease, meaning that in severe disease, it's the virus that triggers the immune system to have an overreaction, and that's what causes severe lung disease. And the reason I was concerned in terms of how the pandemic was progressing was because the simple use of things like steroids were being sidelined. And additionally, we had to be cautious with regards to utilizing the part of the virus that triggers this cytokine storm. So that was where I was coming from. In March of 2021, then I had a breakthrough interview with Gert van den Bosch, and that was huge. And for those people who know Gert, I just recently had a chat with him to support him with regards to his course. That was very important, a very important interview. And then about 2 to 3 months after that, no, it may have been about a month and a half after, I then had someone reached out to me and said, "You've got to interview this guy, Dr. Shetty, in South Africa, because what he is doing is just unbelievable." So I then reached out to Dr. Chetty. I'd not spoken to him before. And so usually before I do a live, I have a chat with the person and we try and understand what we want to focus on. And within a few minutes, I knew that this was going to be special. It was a remarkable interview. It reached over 250,000 people at the time. Sadly, I had to take it down because he started to be targeted on YouTube, where anything around Dr. Shetty seemed to be an issue. Anyway, the point is that his approach to the science in the COVID pandemic, truthfully, was absolutely brilliant. I can't emphasize it enough to say just how remarkable his observation and his thinking was around that time. And the thing that differentiated him from almost anyone else is that he went front and center to treat his patients with COVID. So most other people, like, would read about it or observe it. He went front and center and was treating patients with COVID in early 2020. And that was where he had the remarkable eighth day observation, where he found that patients deteriorated on the eighth day after their initial symptoms. I cannot explain from a scientific point of view how important that observation was. So, what we are going to do today is mention one of the charges that has been brought against him. Can you believe? After he has saved over 14,000 of his patients in semi rural South Africa. And, some people still say, no, it can't be possible. He's making up these numbers. After 3 years, I guarantee you, if he was making up the numbers, his patients would have said, his patients are supportive. They have seen what he has done and they are with him all the way. So, without further ado, let me bring Dr. Shetty to the stage. Shankara, we speak all the time, and I think that this is another one of those where we'll talk about the science. How are you today?
I'm great, Philip, and I hope the audience is all well, safe and well.
Excellent, excellent. So, what we're going to do, Shankara, is that one of the charges that has been brought against you, and actually, just explain to people what is going on in South Africa generally with regards to these charges.
Philip, a lot of people have heard of the work that I've done. I've had a decent impact on my community. The charges have basically three areas that they're covering: the science, my treatment, and of course, my right to speak and say what I think is the truth. Freedom of speech is enshrined in our constitution in our country. We have a democracy that's pretty young, so people are not very, or I'd say, very skeptical about the government we have. And we've seen all the corruption over the past 20 some odd years of uh, supposed freedom. And yeah, we have a very questioning population. So the vaccine program didn't have the impact it wanted to have. People are now questioning the efficacy of the vaccine. We've seen the safety issues. We've had a lot of problems around it. So I think we have a very awake population that wants answers. I also have many in the political, social, and religious fraternity that have been following my work and are very supportive of what I've been doing. So I think I have a lot of support for the case coming up, and I think that yeah, it's an opportunity to highlight the truth,
So what
force people
exactly?
to acknowledge.
Yeah, what exactly are the charges that they are bringing against you in this case?
Philip, the charges are very broad. It's for unprofessional conduct, but the unprofessional conduct deals with three major areas. One is that I'm supposedly making outlandish pathophysiologic claims when I talk about the illness itself and the pathophysiology around it and what triggered the mortality and morbidity. The second is around my treatment protocol intervention, and that I've used treatments that were not sanctioned by the relevant authorities. And the third is my speaking out on the toxicity of the spike protein and the inherent dangers with the vaccine itself. And of course, I predicted that we're going to see uh, side effects from it. Philip, it all stems from a video, a 10-minute video that was cut out of a 3-day summit where I was on the panel to close on the third day. And there was a discussion about the entirety of the pandemic, the masking, the lockdowns, the unscientific nature with which everything was being done. And someone asked, all the doctors on that panel were talking about the irregularities. And I said, look, if you don't understand the agenda, then you won't understand the intervention. It's not about health. And so someone asked, so what is the agenda? And it is at
Oh,
that
don't say
point
it
that my
now. Don't say
conscience,
it now.
my conscience got the
Let me
better
keep
of
you
me, and
away from
I.
controversy.
But the video, Philip, is out there.
Yeah.
It mentioned what I expected to happen. It was my conscience to speak, and I don't think humanity was ready for it, so it caused a lot of problem. But it is the basis of all the charges. And as much as I made that video, I didn't expect it to be cut and go viral that way. But everything I said in that video, I still stand by today. And a majority of it has come true. And so,
Well,
well, the science has caught up with what I was saying. I guess whoever is holding me accountable needs to answer for it.
I think, Shankara, it's difficult for people to understand just how intuitive and how deep your understanding of healthcare is. And I'm saying this as a clinician myself, having listened to you and observed you over many, many years. I've interviewed you multiple times. People just remember something. Whenever I do a presentation, I almost always want to have Dr. Chetty on it because his insights are usually so profound. There are very few people who have that kind of understanding. And I think that there is a degree of what's the word, snobbery in medicine, in that there is an inability to accept that someone who is operating in semi-rural South Africa, not in a big major university hospital even, could come up with strategies that were so profound and so powerful in the context of the pandemic. I genuinely think that's fundamental. They just cannot believe that this could be such a big breakthrough.
Philip, I think that's the nature of my medical career. I've been someone that polarized society wherever I went, and so too with the medical fraternity. When I qualified for medicine, I was an intern, but I was an intern with 7 years of natural science background. So I understood medicine a lot better than a lot of the registrars and consultants. And what I found that was it polarized the community. Those that were truly academics embraced me and were fascinated with my insight, but those that were seeking status hated me in that I was an intern that superseded them. And my principal of my college alluded to that when I was called upon to present as an expert COVID faculty 2 years back. And he mentioned my final exam, where the four of them had examined a patient, a pediatric patient, cardiology patient, and I had to present. And in my presentation, I mentioned some clinical sign that they hadn't observed. And they had to get up and go and re-examine the patient, and came back to me and found, yeah, it was true. And my principal said, at that time you were superseding your peers. And I'm so glad to see you still doing it as a general practitioner. So, yeah, this was never about acknowledgement. It was never about ego. I think it's about, understanding science and looking at the nuances. And I think insatiable curiosity for everything around.
So listen, what we are going to focus on, in case anybody doesn't quite understand, is we're going to just talk through one of those breakthrough insights that he did, that he's being challenged on, and this is about here the antihistamines. He came up with the idea of antihistamines early in 2020, and I'm going to be talking with him about it just to try and explain from my angle how this was so important. So let's just talk through a little bit, because as I said at the beginning, Shankar, what you did, which a lot of people don't quite understand, you went front and center to see your patients when they had COVID. You didn't tell them not to come. You actually asked them to come so that you could examine them to understand what was going on. So you had an insight that very few people in the world could have about patients and the trajectory of the disease. What made you think of antihistamines at the first point? When was the first point you thought of antihistamines?
I think it was when I started using the steroids, Philip, very early on in the pandemic. I think we're talking March, April, the first few cases that we saw. It was, Philip, it was the nature of the symptoms and the way they presented that drew my attention to the benefit antihistamines might have if I understood clearly what my theory around the underlying pathophysiology was. And I think that was the vitally important thing. The way the patient presented with the illness, how the illness evolved, dictated what the underlying mechanism would be. And the differential of that underlying mechanism would dictate the kind of treatment I would try. Every patient is a therapeutic trial. When a patient comes to you with the flu, we don't do tests to clarify it's the flu. When we treat them and they recover, we know it was the flu. So every patient's a therapeutic trial using differential diagnosis and treating the most appropriate diagnosis. And if we fail, then we go to secondary diagnosis and investigate further. It's the nature of how doctors treat patients. And so it was just a natural progression of examining the patient, looking at unusual symptoms, and trying to figure out what might be going on in the background, in the pathophysiology, and what might improve that or treat that. And then from that, you look at speed to recovery. You try
Hold on,
different things and see how quickly patients recover.
I want to explain something to the audience in case they don't understand this, because when it comes to sudden respiratory compromise, because this is what you saw with the patients, is that literally within a few hours they would go from seemingly well to being extremely hypoxic. That means low oxygen saturations. Just in a clinical context, there are only a few diseases that do that. One of them is flash pulmonary edema, where the lung gets full of fluid with heart failure. And the other one is an allergic type response. But I remember when I was researching it, I was scratching my head trying to figure out what else could do it. I came across high altitude pulmonary edema as being, so I was trying to figure out how could it be so quick, and where it's not necessarily one of those two conditions, because I wasn't thinking of that kind of allergic type response, which is usually mast cell mediated. What made you go for that as opposed to anything else? You didn't try diuretics, did you, Shankara? Hmm. I was thinking that he was looking at me interestingly. Instead, I think his screen is frozen. So let me just try something else here. Um, Shankar, are you back?
Yes, Philip, can you hear me?
I'm hearing you now. I was just saying, yeah, you were looking at me in such a clear and focused way that I thought to myself that it must have been that you were just transfixed with what I was coming. I didn't realize you weren't there.
I don't know. I don't know on which side, Philip, the connection's not that great.
Yeah, yeah,
Because
yeah. So,
everything seemed to be moving here on my side. I thought it was your connection, but it seemed to be me that was open.
so yeah. So I was just saying, when you did that transition to antihistamines, as opposed to say heart failure, where you get that very rapid deterioration, what made you think of antihistamines first?
Philip, when I looked at the illness itself and the way it presented to me, I realized I'm dealing with an illness that has a biphasic nature. I had patients who came in with an ordinary sore throat, loss of smell and taste, the usual. I had to figure out those patients uh, whether it was COVID positive because I had a PCR test I couldn't rely on. And so I had to interrogate the symptom that was unusual was loss of smell and taste. And so it's unusual in the flu to lose your smell and taste. Everything else was very similar to the common flu. So I interrogated that symptom, and what I found that was the taste was lost to sweet and salty, but bitter was preserved. So it's a simple test to do to keep a little container of salt and sugar and lime on your desk. And when the patient comes in, you ask them if they can taste this. And it was very unique to have bitter preserved. And so it confirmed COVID for me. It was a better method to test positivity in COVID than a PCR test. And it worked for everyone in the family that was infected. So I watched these patients. They had a flu. I was worried about the breathlessness. So I asked them to come back if they got breathless. And I had the first few come back. But this desaturation that occurred on that eighth day was very rapid. Where on the seventh day, the patient was perfectly fine. They looked like they recovered. And I couldn't see a correlation between the two phases, meaning the patient that was very ill with the viral illness, high fevers, lots of constitutional symptoms, recovered and didn't have the eighth day issue. And some that had very mild initial symptoms that subsided within a day had very severe reactions on the eighth day. So I saw no correlation there. And so when I had this desaturation on the eighth day and such a sudden, rapid desaturation, there's only two things that I thought pathophysiologically could lead to such a rapid decompensation. One is severe allergic reaction to an allergen. The second is a response to a venom or a severe poison. And so I looked at that and I thought, well, I must be dealing with an allergic process on that eighth day. And so that's where initially the steroids, I used the steroids. It's a steroid responsive illness. We knew that. I looked at speed to recovery with the first 4 patients or 5 patients. I knew it took about 4 days to see good oxygen saturation rebound from the decreased sats I was seeing on the eighth day. And on that fifth or sixth patient, I decided I'm going to try an antihistamine because this looks like a allergic process. And the therapeutic trial of antihistamine actually doesn't put my patient at risk. And so I gave that particular patient a single day's dose of promethazine to see if I improved the speed to recovery. And that worked. The very next day, she had shown clear signs of improvement. She was almost back to her old self, but I had only given her a day. And so the following day, there was no antihistamine there, which means a withdrawal as well. And I explained to her that the breathlessness might come back. It did. And so I put her back onto the steroid a day later and she recovered. I think that's the best evidence of antihistamine working. I
Yeah,
gave it to her. I showed the speed to recovery. I withdrew it. I showed her worsening. I put her back on it and she improved. So I don't see
yeah,
why an antihistamine needs to be tested further.
yeah.
That's
So
the best kind of evidence.
there's something I wanted to catch you on. I didn't want to interrupt your train of thought, but you said something a while ago that I found very interesting. You said that you found patients lost their sense of smell
Yeah.
and their taste, but they still maintain their ability for bitter taste.
Yes. Bitter was preserved, strangely.
Wow.
And if you ask patients, if you just generally ask patients, they would say, "No, I can't taste my food." But another comment was, "Everything tastes bitter."
Shankara, this is too important. I want you to jump out and jump back in because you're breaking up quite a bit. Just jump out and jump back in.
Okay,
I'll talk about share some other points with the people in the meantime. I want to catch those points. So you jump out, jump back in, and I'll show something else.
okay,
Yeah. So while Dr. Shetty is doing that, I'll show you all some important principles about the lungs. So you have to remember that the lungs are quite remarkable. They're there to exchange oxygen and remove carbon dioxide. The surface area of the lungs, when you break it down, is like about the size of half a tennis court. So it's quite large. Um, and the exchanging part is down to the alveoli here. So you can see that these bronchioles bring air in, and that's where the exchange, and you can see the blood vessels here on the surface of the alveoli. This is where all the exchange of oxygen occurs. There are about 480 million alveoli in the lungs. So this is a big surface area. Now, when I'm going to come back to that slide, when you have severe COVID 19, one of the things that happens, or once you have, I shouldn't even say severe, once you have the inflammation in the lungs of COVID, is that you end up with a big accumulation of almost all the white cells going flooding into the lungs. One of the big ones that are causing problems are the macrophages, really struggling to. These are the ones that tend to pick up the viruses. They are antigen presenting cells. So you have a big pull into the lungs for all these inflammatory cells. So the question I had, as I said, I was interested in what Dr. Shetty did. I had to go back to the science because I was saying, if the antihistamines work, what was the mechanism of it working? This is an important point, is that some people would say antihistamines can't work because they shouldn't work. And I'm thinking, no, if you're a scientist, the question is not that something can't work. If something works, your question is, how does it work? What is the mechanism? And if you are not doing that, you're taking a political and ideological stance. My position was purely scientific, it was not ideological. Anything that worked, I was willing to go back to the science to try and see if I could understand what the mechanism was. So when he mentioned that issue with regards to antihistamines, I then went back to the science to try and make sense of it. Let me just quickly check. Actually, Shankara, are you back here with me?
Yes, Philip, can you hear me?
I'm hearing you. Let me just see. You're still freezing a little bit. Go on, keep talking.
I'm not sure. It's a network problem, Philip. I've been trying different.
Well, what you do for the time being, Shankara, switch off your video. Let's see what, as long as your sound is working, that's fine.
Is this better, Philip?
Hmm?
Is this network better? I've just swapped networks.
It's not necessarily, but switch off your video. Let's see if, as long as we can get the sound.
Yeah. Okay, let me just.
Yeah, there we
There
go.
we go.
Just keep talking. Yeah. So yeah, I was saying, Shankara, that I was just explaining to the audience about the inflammatory process that occurs in the lungs, and I was saying to them that, listen, when when you're a scientist as opposed to an ideologist, from a scientific point of view, any observation is valuable, and you don't ignore it. Some people will ignore observations because it doesn't fit a narrative. Those are not
Yes.
scientists, those are politicians. Because anybody who listened to you should immediately have asked themselves, wow, how the heck did he manage to get that to work?
I think, Philip, the clinical presentation is always vitally important. When I looked at these patients coming back on the eighth day, the world was talking about a viral pneumonia.
Mm.
That's an infective process. Now, if I had to look at the clinical presentation, you had a patient in front of you who was constitutionally well. He didn't have a fever. He didn't have all the constitutional symptoms of a viral pneumonia, body aches and pains and that kind of thing. He was just very breathless. Now, breathlessness as well needs to be defined. He had no restriction in his ability to inhale and exhale. So he had no wheeze. There was no increase in his expiratory flow, peak expiratory flow. So he could breathe in and breathe out easily. There was no asthmatic kind of wheezing sounds. Then, as well, when you listened closely to the lung itself, there was no crepitations, which shows extravasated or fluid in the lung, which
Hold
you'd
on there,
find in
Shankara.
pneumonia.
There's an important point you said there. One of the things that was most remarkable is that they were saying that when patients were on intensive care, and that they were using the ventilator. Normally, in something like ARDS, which is an inflammatory syndrome that can occur with other viruses, the lungs are very stiff. And so they
Yes,
have to use high pressures to inflate them. They never found those problems generally with COVID patients. And that mirrored exactly what you were saying, is that when you are listening to their chest, they're able to take deep breaths. It didn't seem soggy or wet. They just couldn't get oxygen exchange.
exactly. Exactly, Philip. And my thoughts were that the lung was not, the exchangeability for oxygen was not restricted because of fluid in the alveoli, rather the extravasation of fluid because of an allergic process caused edema of the tissue of the alveoli. So the alveoli were swollen and they couldn't absorb any oxygen, but there was no fluid in the space of the lung itself. And another thing I found, Philip, there was none of this wheezing kind of sound, but the patients, the only thing I found was that the patient couldn't take a deep breath. He couldn't take a deep breath. Breathing was easy, it was clear, it was unlabored, but they couldn't take a deep breath. So the capacity of the lung to expand was restricted. So the
And so that
elasticity of
made
the
you
lung was
think you,
compromised.
so that made you think more of bronchoconstriction.
No, even with bronchoconstriction, you'd see an increased length of expiration, like in
Yes.
asthmatic.
Yeah.
They could breathe easily. I asked patients to take a breath and blow, and they could blow out that air very easily. So it showed there was no restrictive pathology there. They could get out the air very easily. So using a bronchodilator wasn't going to improve the situation. But they had these low oxygen sats and the high respiratory rate, but they were breathing very shallow. So it showed that the capacity of the lung had decreased, the literage of the lung had decreased, and it couldn't expand to its full capacity. So you needed more breaths per minute to keep oxygenating. And so
Yeah.
this breathlessness.
One of the things that I found was under investigated in the pandemic was the fact that I've shown here a picture, Shankar. I hope you can see it.
Yeah.
Healthy lungs over here and inflamed lungs. And one interesting thing is in the week where they had mild symptoms, if you were to do a scan of their chest, or sometimes we would do x rays and find that there is significant infiltration, even though the patient felt relatively well. Did you notice any of that?
Yes, Philip. Patients presented, like with an allergic process, with a variety of severities on the 8th day. We had patients that were breathless. Their saturations didn't drop that severely. It was in the 95%. And within a day or two, they improved without treatment. They came back and said they got breathless on the 8th day, but they couldn't get to me, and a day or two later, they were fine. Some of them were very severe, where they came to me from the morning being tired to the evening being completely breathless. There was a difference in speed there. But all these patients had lung pathology. And then we were seeing these ground glass appearance on CT scans and x rays, and they were reporting that as a pneumonia. But a ground glass appearance is a differential diagnosis for either a pneumonia or a pneumonitis. So it just shows inflammation. You've got to clinically verify whether you're dealing with a pneumonitis or a pneumonia. The X-ray or CT scan cannot differentiate those two. So on clinical presentation, I knew clearly I was not dealing with a pneumonia. It didn't have the classic symptoms of a pneumonia. And that's when I realized, no, we're dealing probably with a pneumonitis triggered by some kind of an allergic process. And that was the push to try and add an antihistamine to look for benefit, improve speed to recovery.
Yeah, so one of the things, and just so people understand, is that scientists don't always agree on everything. So, meaning that myself and Dr. Shetty both agree on the fact that this is immune mediated, but Dr. Chetty tends to focus more on the allergic side of things. I focused on the autoimmune side of things. So, Shankar, I'm going to share with you my thought as to how the antihistamine makes a difference, even though it may not be an allergic process, if that makes sense. Okay.
Yes, yes.
So And I've always said this is viral mediated autoimmunity. So the virus triggers an autoimmune response. And we had said that it was to ACE2 because this is the characteristic of the people. They're overweight, they've got diabetes, they've got hypertension, they've got heart disease, all of the characteristics with high levels of free ACE2. And the reason you ended up with the eighth day was because the most consistent thing was the transition from the IgM to IgG antibodies. And so our theory was that you then had a situation where this is the surface of a macrophage. This is one of the immune cells with ACE2, because some of the immune cells had ACE2 on the surface, including platelets, actually. So then what would happen is that on the eighth day, you have IgG antibodies coming. They target the ACE2 on the surface of the macrophages and platelets as well, actually. But for the purpose of the histamine here, this is the bit that I was saying. And then what you have is that the macrophages then become hyperactivated. And this is manifested by an elevated ferritin level. So the ferritin goes up. It's not from the liver, it's from these macrophages being activated. You then go from a normal macrophage to a very stimulated macrophage. This macrophage then starts releasing specific cytokines which cause the mast cell to degranulate. And I went back to the research at the time, and the critical one was macrophage cytokine protein. Did I get it right? MCP1.
Chemotactic.
Chemotactic protein, yes. And so this release causes the mast cells to degranulate, which would then cause that very sudden deterioration. And this would then explain, because you then pointed out an important paper, but this would explain why right at the beginning antihistamines would work. And you had found that if you used it later on, it wasn't as effective.
Yeah, not as effective as it was on the eighth day, Philip. It did have benefit, but what I found was that if you delayed antihistamine, then the speed to recovery was delayed. You had a patient ill for longer. So that was the strange thing. In that, if you caught the patient on the eighth day, treated them aggressively, by the ninth day they showed good signs of improvement, and by about the 10th or 11th day they were out of the woods and they remained well. If you caught the patient on the 10th day, it was going to take you 2 or 3 days to get the same recovery that you got in one day from the eighth day. So it showed that leaving it unchecked was triggering a host of other issues coming through. The cytokine release, the inflammatory process, the thrombogenesis, the coagulation problems. And so it went from a simple release of cytokines to a hyperinflammation, which would take longer to reverse, to a
Mhm.
hypocoagulation, which would take even longer to reverse. So it became vitally important that I catch these patients on that eighth day to mop up those cytokines before the cycle breaks free. You can see that there's a bit of a cycle. When you get histamine release, it triggers more histamine release. And that's where you need to stop the cycle immediately. Because once you leave that in progression, you get other mediators involved, other cells involved with a more chronic inflammatory process setting up, or more an acute inflammatory process where you didn't have an inflammation to start with. And now you're dealing with a bigger problem.
And just to corroborate what you were saying, this was in 2020,
Yeah.
and we know Kenneth Day and Marcus Sanchez Gonzalez. I think I've spoken with both of them, but they were looking at a pathophysiological perspective on COVID-19's lethal complication from viremia to hypersensitivity pneumonitis-like immune dysregulation, which is fitting in almost exactly with what you're saying. And
Yes.
what they showed here, and this was the thing that they showed here. So remember, we mentioned mast cells. They found that mast cells were 1,000-fold higher in the bronchoalveolar lavage of these patients, and analysis of excessive amounts of histamine in the fluid suggested that the lavage procedure may promote mast cell degranulation. Actually, I think they were seeing that the mast cells were already degranulating,
Yes.
fit with what you were saying, which is why at that point, antihistamines would have been such a valuable tool.
Yes. Philip, one other, with Marcus and Kenneth Day, we discussed, and they were looking at more type 2 hypersensitivity, where immune complex mediated. I was considering a type 1 hypersensitivity. My thinking was that if I was getting this quick speed to recovery, then I was having a very select process to deal with. When you're dealing with immune complex mediated illnesses, they take a little longer to get recovery. You don't have this miraculous overnight kind of recovery. And what I was why I thought type 1, Philip, type 1 kind of hypersensitivity requires a sensitization of those that are allergic to the allergen prior to the reaction. So if you're allergic to something, you don't react on the first exposure. You develop the inappropriate antibodies on that first exposure, and you react on the second exposure. And what drew my attention to it being type 1 was that in the first wave, we were having people over 55 distinctly affected, and people under 55 weren't affected. So you could draw this line through the pandemic. And I kept wondering why this line? Because allergies affect all above a certain age. It's only in an immature child's immunity that you don't get these severe reactions. And I understood why children were going to be spared in this illness. But what I had predicted was that those below 55 were not sensitized for some reason. So there was some event that happened 55 years and longer ago that seemed to sensitize that population to that allergen. And 55 years ago, whatever that sensitization was stopped. So we were now sitting with the population where those over 55 were sensitized and those younger than 55 were not. Looking at
Well,
that, I needed to clarify two things. One, if that was the case, then those under 55 would get exposed in the first wave and not have severe illness, but would be sensitized by it if they were allergic. And that was a prediction I made to say in the second wave, if this lower age group was sensitized in the first wave, we're going to see severe disease in a far younger cohort from the second wave onwards because they've been sensitized. And we saw that happen. The second thing I needed to look at was what was so commonly used 55 years and longer ago that covered an entire globe of the population that suddenly stopped 55 years ago. And the only thing I could think of was, Philip, was the liberal use of DDT at that time. We used the DDT was being sprayed in schools. It was being used. It was this new miracle that could eliminate malaria and things. And it was 55 years ago that they realized the toxicity and it stopped. They stopped using it in wide use. So I kept looking at that, thinking, was that the event that sensitized humanity? The use of DDT, the liberal use of DDT around the globe. And
yeah,
stopping it 55 years ago, did it sensitize a certain cohort that showed up in the first wave as severe illness?
yeah, I
So
think
those were
that
the things that drew me to sensitivities, you know?
yeah, and my thought would be is that I find, because I found that the sequence was so complex to try and understand, that I have always found that just saying an autoimmune response, it's very hard to go wrong, because even if you said type 1 hypersensitivity, that's still autoimmunity. So
Yes,
I would probably drift more to a type 2, type 3 hypersensitivity response with some type 4, meaning cell mediated immunity as well. And that's where I think that you have a little bit more leeway. But if you tie it too strongly, I think, to
yes.
more of an
You're correct,
allergic
Philip.
response, I think that you could, that's harder to sell as opposed to an autoimmune or an immune dysregulation response that
Yes.
has been triggered by something else.
Yeah, you're correct, Philip. And I think where the confusion set in was that we had initially three different lethal waves. And the clinical observations or responses in those waves differed. Now, in the first wave, I could give a patient a steroid on the eighth day and an antihistamine and the rest, and no matter how ill they were, I've had patients with 70% saturations that were saturating 100% 10 hours later. And that shows a very quick speed to complete recovery. When we got to the second wave and the gastrointestinal symptoms, it took a little longer. So the underlying process wasn't simply a type 1. By the time we had gotten to the third wave, the consideration for me was, are we dealing with a type 3 kind of immune complex mediated disease that's causing all the other disastrous effects? So I think the different variants, as much as they affected the immunity in the very same time frame, they influenced it a little differently with each wave. And so the speed to recovery with antihistamine, steroids, the usual standard methodology, took different lengths of time to actually give me the same benefit. I was having patients taking longer to recover in the second wave with a higher dose of steroid. And in the third wave, even longer, where the anticoagulation became an issue, no matter how quickly you caught those patients. So
Yes.
it
Yeah.
showed the mechanisms that slowly, I won't say evolved, but changed.
Mm. Yeah, so I think that just so that people understand that this is technically the pathophysiology here. This is a normal lung here where air can come in and exchange with the bloodstream here. And in the context of severely inflamed COVID lung, there is some fluid in the alveoli. There are lots of clots and nets forming there, so the blood can't get through. The platelets are hyperactivated. This is what causes the microclots. In my view, it's technically a vasculitis affecting these blood vessels here. And this is what triggers all the clots. And that's why the patients can't actually breathe. But if you can prevent that from occurring, especially early on with the steroids and the antihistamines, that's how you then end up with the benefit. As I said, when I look clinically, some people don't understand. Sometimes you have a patient who is short of breath. You don't know necessarily whether or not it's pulmonary edema. You don't know if it's an exacerbation of COPD. And you sometimes have to use all the tools in the toolbox just to get them better. The point is that you never discount when you've done something that gets a patient better. You then try and study it more to try and understand the mechanisms. That's where I think, Shankara, you are at a completely different level. You probably had a better opportunity to do that because where you were, there was no option largely but you.
Oh.
Are you there, Shankara?
Yes, yes, Philip, I can hear you. I think you went off just for a few seconds there.
Yeah.
Yeah, Philip,
Mm,
I was in a unique situation in that I could examine the patient and see exactly what was going on. From that, just to clarify, Philip, from that slide you just showed, uh, when you have a severe process, immune dysregulatory process, you get the extravasation of fluid into the interstitial space, but not into the alveolar space. So I was seeing no crepitations with fluid, but the lungs were swollen. Now, where
mhm,
I clarified that, Philip, if the lung is swollen, you've got a vessel that's lost fluid, and so the circulation is compromised, and you've got the tissue that the oxygen must traverse to get into that vessel that's swollen or full of edema fluid. So antihistamines tend to help take away that, revascularize that fluid. Now, where I really clarified that, the ideal drug of choice in that kind of reaction would be adrenaline. Now, adrenaline is a difficult drug to use, especially in a setup where I can't monitor patients. You've got to have patients on a heart rate monitor and be able to do ECGs. It's a dangerous thing to give a patient adrenaline without the high care facility around. So, what I did was, I had patients, Philip, come to me too late on the 12th day and 13th day, struggling through the breathlessness. Now, it's at that point where the fluid that's in the interstitial space starts to ooze out into the alveolar space. And we hear that kind of respiratory crepitations in what we call Kind-Stokes respiration, where
mhm.
patients start to go in the death spiral. You hear that bubbly, that cardiac failure kind of sound in the lung. And when I had these patients come to me, I nebulized them with adrenaline. Now, nebulizing with adrenaline takes the adrenaline to the site of the injury, but doesn't really give me the systemic problems. So when I
Yeah.
nebulized the patients, I was looking for subsidence of those crepitations, showing that I managed to get the fluid back into the vessel. And I noticed that when I was treating patients, I did it not on many patients, Philip. I must have done that for about 30 or 40 odd patients in that first wave. And I managed to reverse that critical situation.
Yeah.
And so, yeah, everything worked towards the same. pathophysiologic theory. And everything that I touched and tried with that understanding seemed to improve the outcome. And that's what
Yeah.
fortified my understanding that I'm dealing with an immune dysregulation.
Shankar, we're just closing out now. We've been talking longer than I had planned. But just so that the audience understands again something. I've observed some of the comments on here, and there are a few people who seem to think they understand science and so on. But I'm telling you, from a patient point of view, when you have patients dying across the world, and you have somebody who can do this. And listen, as I said, listen, you stopped counting the amount of patients that you treated who did not die with your protocols. I have no interest in anybody who doesn't have those kinds of stats. Those are some incredible statistics. And this is what I find sad, Shankara, is that when you reflect on what could have happened across the world if people had been more open and had actually listened to innovative ideas, listened to people who were at the front line, who risked their lives to observe patients. Think about how many people could have been saved with simple, readily available therapy for which you then used and you gave to other countries to help them to make a difference. So I think that what I am trying to highlight to people is that when you have the heroes like Dr. Shetty being targeted because he's saved so many lives, but done it in an innovative way, if that's the kind of medicine that you support, I warn you about the years ahead, because COVID 19 is going to cause one storm of disease that you have to be innovative and creative to figure out. So, if you hope to use protocol based medicine, I wish you luck. Any thoughts, final thoughts on that, Shankara?
Yeah, Philip, I think we need to relook at how scientific evidence is presented. I think we know about the journals that have been publishing hit pieces on certain medications, and so those that are the custodians of knowledge can't be trusted. And I think we need to look at as well what is actually knowledge. A randomized clinical trial is not going to bring us innovation. We use multi-drug therapies in a lot of illnesses, and randomized clinical trials are not structured for that kind of thing. I think the observational skills and the experience of clinical practitioners has been sidelined. I can cure a patient and have a miraculous recovery, and it gets lost in my clinical records. So I think it's vitally important we bring back the doctor's lounge, where doctors share innovative ideas, share their experience, and look at how we can best treat the patients in front of us. And once we get those miraculous recoveries, dictate to research where to look for the benefit of the patient, not to do research for the benefit of profit and try and adapt that to the patient in front of me.
Excellent, Shankara. And so, final word to the audience. Remember, those who fight for you and those who try and find solutions for you, you must support them, because the ones who don't are not looking out for your best interest. And we need more than ever people who will fight and advocate for patients at these very difficult times. Shankara, stay with me, but thank you everyone for being with us. We hope that you found this information valuable. Thank you.